Okay, I think you can hear me. Good morning, everyone. It's 8 o'clock. Thanks for joining us. We're on week 8. If you would please chat your name in the chat box to record your attendance this morning. If you're on the phone and you need to unmute yourself, the code is *6. Otherwise, please mute yourself unless you're speaking. If you have issues, there's a tech number here. That's Rick's phone number. Please call if you need to. We're going to go around the room and introduce ourselves.
Jim Werner, Case Western Reserve University. I'm a behaviorist.
Jackson Wright, Case Western Reserve University, Professor of Medicine, and co-lead of Team Best Practices for Cardio.
I'm Rick Renacci. I'm the web content producer for Cardi-OH.
And I'm Shannon Spikowski, the clinic coordinator. And I'll turn it over to Dr. Werner, who is going to be our facilitator today.
Great, thank you. Welcome, everyone. Thank you for being here today. So I think it's going to be a fascinating presentation and case study that we have. So today, Chris Taylor is going to present and provide an update on lifestyle changes for blood pressure control. And then we'll have a case presented by Anissa Shomo from the University of Cincinnati Health Department Community Health Center. That's our agenda for today. Please type your questions and comments in the chat box and we'll get to those. So let's turn it over to Chris.
Thank you, Jim. I'm going to work through the presentation today, talking about lifestyle changes, building on what we talked about before with sodium and kind of taking it a little bit broader besides just sodium restriction. I'm pinch hitting a little bit, so bear with me as we move along, shifting up our content so we can go ahead and move forward. And I think one of the things that has become readily apparent as we talk about the different cases that we've had thus far is that managing hypertension is this kind of push and pull this push and pull and kind of balance back and forth between how do we manage blood pressures pharmacologically, but then also how do they respond and how do we incorporate treatment of both physical activity and dietary patterns from the lifestyle perspective. So we've had a lot of conversations about medication management, but also talking about different strategies that we can improve blood pressure control. Next slide, please. So we talk about sodium restriction, and we had an entire session kind of focusing on sodium and its potential aspects. And one of the things we're seeing out of the new dietary guidelines panel that's being convened right now about creating our kind of national standard for healthy eating is in the last 5 to 10 years, we're really seeing the shift away from kind of individual nutrients and starting to look at the broader patterns of what we would like people to eat. So the DASH diet was the diet that was tested for dietary approaches to stop hypertension. And it creates a much more robust look at the dietary intakes than just kind of focusing solely on sodium. So these potential patterns that we're trying to evaluate include eating whole grains, lots of fruits and vegetables, low fat or fat-free dairy products, lean meats, plant-based proteins, choosing our fats and oils from more unsaturated sources, and minimizing our sweet intakes. And this probably sounds familiar because it aligns with a lot of our other dietary recommendations. Next slide, please. So we're seeing this consistency in storyline. Fruits, vegetables, whole grains, healthy fats from unsaturated sources, more from unsaturated sources, lean and plant sources of protein, limited added sugars and fat. These are the same guidelines that we see within the U.S. dietary guidelines, and then resultantly the My Plate Eating Plan. DASH promotes these, Mediterranean promotes these. And in some ways, I would say it sounds redundant as we continue to hear these, but I think it underscores the importance, as well as kind of how poorly we're doing at aligning with these recommendations. So starting to think about dietary practices a little bit more than just what is the sodium content, but what are the other food sources that we can be promoting. One of the big challenges we had with the whole everyone should eat low fat situation was substitution is typically kind of the biggest problem. We can remove certain things from our diet, but when we remove things, we have to remember, what are we putting back in? Every change is Newtonian. For every action, there's an equal and opposite reaction. So every time you take something out, you're going to put something back in. In the case of low fat, we decided low fat was better. So therefore, we put in more refined grains. We added sugars in. So the ability to think about what these potential changes need to be, and how they play out in a broader scale, become important. So if we continue to improve and consume more fruits and vegetables and more whole grains, more lean and plant sources of protein, it is going to, or consequently, decrease sodium intakes, by the nature of the types of food selection. So in this point, I wanted to bring up a really quick kind of common buzz term that's being used in terms of a plant-based diet. A plant-based diet does not equal vegan. And a plant-based diet does not necessarily mean vegetarian. But it's the shift in focus to continue to look more at sources of plant-based foods compared to animal-based foods. So if you look at the list on the left, it doesn't say you can't eat animal protein. It just says you should be choosing lean sources of animal protein if you're going to consume it. And the same with the diet eating plan, lean sources of dairy. So plant-based is one of these terms that's used in a lot of the recommendations. It doesn't mean that we should not consume animal products, but it's talking about making a shift more towards plant-based products. On to the next slide. So one of the things we have to do now in looking at this broader picture is, I think we're hard pressed to walk around and ask somebody on the street, are fruits and vegetables good for you? And 99% of the people are going to tell you, yes, fruits and vegetables are good for you. And I know I should be eating them, but I don't. So we know what the recommendations are, and individuals know what the recommendations are. They know that eating a large amount of sweets is not good for their health, but getting them motivated to change, and this is something Jim's talked about with motivational interviewing, there are lots of other factors that drive why people eat what they do. So the U.S. Preventive Services Task Force recommends that to really achieve meaningful behavior change, medium to high intensity lifestyle interventions are needed, which medium intensity, we're looking at 31 to 360 minutes. And high intensity means 360 high intensity kind of behavioral counseling. Time needs to be invested to really get to the root of problems and make these changes. So when we look at these recommendations about how we make this happen, we need to consider, what are our capacities? What are your limitations? How much time do you actually have to spend with these individuals? How can you determine your role to either be a reinforcer or a facilitator of getting them to the correct information, or if you're going to be the primary vehicle to help them make behavior changes? We also have to kind of consider what our capacities and our limitations are. What are our scopes of practice that allow us to talk about individualized patient needs, and what are the licensure implications? So if we know that we're not the individual that is essentially legally allowed to provide this kind of personalized counseling, or we know we don't have the time, how can we figure out ways to get them to that? which then means lifestyle behavior modification really means we have to take those guidelines and figure out how to overlay them onto an individual's personal situation. We've talked an awful lot about social determinants of health and the ways that we can actually help an individual increase their fruit and vegetable consumption on a budget or without refrigeration opportunities or cooking skills. So we need to figure out what ways can we make that happen. And one of the shifts that we see in looking at these broader kind of food recommendations and getting away from individual nutrients is that people actually eat foods and meals and not individual nutrients. So if we focus a lot on the individual nutrients, we want you to eat less saturated fat and eat less sodium and eat more fiber. They're not particularly certain how they get that onto a fork. So we need to provide that guidance. Next slide. So one of the things that we've seen in different areas of primary care and a lot of these different initiatives that have taken shape, I wanted to kind of address quickly and then give a real quick case of how we've kind of approached some of these concerns. One of the things that's come out has been the prescription for fruits and vegetables, prescriptions for physical activity as well, which are an indicator of the physician or the primary care provider basically making a written statement that says, this is something that you need to do that's important for your health. And I think those are very important and powerful messages that patients need to hear, because they'll hear you need to eat better. Yeah, I know. And I want you to take your medicine. Have you been taking your medicine? Okay, these are the things I want you to do. But have you been eating better? Well, I want you to try more. So the prescriptions really do put into place a statement of value around making these behavior changes. But I think we've all heard individuals say, I got a prescription for this medication and it's really expensive, and now I have to pay for it out of my pocket. And if you translate that into fruits and vegetables for the individuals who are having those types of financial challenges, their ability to act upon that prescription, just like receiving a prescription for a medication that they may not be able to afford, can lead to potential challenges for them in carrying them out and potential frustrations. And then the other side to that is the coverage for lifestyle behaviors. Is it going to be provided by the primary care provider, which by much of our evidence shows that it's a very brief window of time that's available because visits are just not very long to begin with. So is that information going to be provided within the visit as in more of a reinforcement strategy, or is it going to require a referral out? And then what are ways that you can then identify if you do need to refer out? Do you have someone in your office, or do you have to link them up to someone within the community? So as I've mentioned before, the Find an RD registry at 8right.org is a place where dietitians can actually post that they take clients and what their specialties are. So that can be a place that can help you find someone to send them out to. But I think the other broader piece that we've looked at from our research is about how to foster that communication. Because typically providers are responsible to the payer. And if an individual is paying for the services on their own, the provider typically then would be responsible to the person who's paying them, which would be that patient. So if there's no requirement for them to report back to the insurance company to get paid, or they're reporting to the insurance company to get paid, that doesn't particularly mean that the person who's facilitating their care is going to be receiving the information to know what they've addressed, what their goals are, and how to move forward in that manner. So I think trying to foster communication will be an important aspect. Next slide, please. So one of the ways that we've tried to address this from this patient-centered medical neighborhood type of approach was to look for individuals that had high blood pressure or hypertension. Find those patients in primary care, we linked those patients up to a dietitian in the grocery store situation. So they were able to, the physician would identify patients that met the eligibility criteria, basically stable medication history, history of high blood pressure, and ask those individuals, I think this is important. They then receive 3 personalized counseling visits of 60 to 90 minutes each. And then we had the dietitian create those clinical notes and share them back to the primary care provider. And what that allowed us to do was essentially see a significant improvement in diet quality. But the thing that the patients really told us on the other side from the interviews was, I knew it was something important I needed to do. My primary care provider then said, this is something that's important to me, so I took action on it. And then they went back and they were able to get reinforcement of those behaviors, and it made them much more likely to make those changes. So next slide, please. So this just kind of gives an indication of the capacity for change. So we were using a food frequency questionnaire as part of this project, and we were ultimately able to see about an 11-point increase in their overall diet quality from beginning to end based on the dietary survey they completed out for us. From our evidence, basically about a 6-point change has been linked to about a 15 to 20% reduction in all-cause mortality. And this kind of gets us at twice this level. Knowing that it is a self-reported questionnaire of dietary behaviors, there is the potential bias, but at least in this situation, it gives us an indication of knowledge change. And from the discussions, their behaviors are, they're describing are kind of aligning with the data that they're telling us. So we're able to see an actual significant improvement in diet quality from kind of fostering this collaboration. Okay, so next slide, please. So the other element that we wanted to look at working with some of our dietitians was that they knew that they were seeing patients, they're booked out for 3 to 6 months, and they know that they're seeing patients, and they know that there are challenges to getting reimbursed. So we did a chart review of the patients that are being seen, who is being billed, who is being referred, what kind of coverages are being spent by the different providers. And there was an assumption that there was poor reimbursement and it was kind of a fiscally unsalient model. But what we were ultimately seeing was most of the visits that were being referred were for weight management and for diabetes control. And actually less than 10% of the referrals within that one time period were for cardiovascular disease or hypertension. So it creates an opportunity for us to take a more active role in lifestyle management with hypertension. And the assumption was there was a lack of poor reimbursement. So let's go to the next slide, please. So what we actually saw was private payers were providing the bulk of the payments that were coming back, 75%, which was an unanticipated result and often a challenged statement until we had the fiscal data. Next slide, please. And we could see basically how much time was being spent in units for counseling and how much of the payments that were coming back for each one of those. So glycemic control and weight management were both the most amount of time and payments, but it was and less on the hypertension. But we were seeing that there was this capacity for reimbursement, especially through private payers in providing nutrition counseling. So what we basically identified was they were receiving approximately twofold their salary in reimbursement, and we were then able to use this information with the fiscal officer to increase the FTE and give them more opportunities for continuing education, because we now have some evidence to support the ways that we can improve lifestyle behavior management in primary care. Next slide, please. So now I quickly want to move through some exercise recommendations and how we can apply those to hypertension. Give some credit to Emily Guzman, who was my co-presenter on our previous coverage. Next slide, please. So we have new physical activity recommendations which came out within the last year or so. The previous recommendations were released in 2008, and they hadn't changed greatly in that amount of time. And we're still looking at at least 150 minutes a week of at least moderate intensity aerobic activity, and then adding in at least 2 days of some muscle strength training activities to promote health. Next slide, please. So the key points in translating this into hypertension management is that we need to be focusing on regular physical activity on most, if not all days. So really trying to continue to push the envelope for energy expenditure. And I think one of the other more important aspects in this identification of moderate and vigorous intensities to promote activity is to really think about and have them be intuitive about how much activity is truly moderate and how much is truly vigorous. Because moderate is defined as being able to get your heart rate and your breathing rate up into higher thresholds. So while getting individuals out and moving and strolling is better than sedentary activity, what we're looking for in terms of moderate activity needs to be elevated to a level that then gets the heart rate up. So just kind of going out for a leisurely stroll and walking the dog. They walk the dog like mine, who sniffs everything. I never get my heart rate up. Are the types of activity that are needed to really push that threshold. So kind of resetting that equation around how much activity is really moderate level physical activity. A lot of individuals say that, yeah, I'm on my feet all day and I walk for 8 hours a day. But walking for 8 hours a day in a clinic to an extent of getting your heart rate up to that level and sustaining that as a moderate level intensity would probably require knocking people down in the hallway of kind of running back and forth. So reshaping where our moderate and vigorous intensities are so that we can really translate those recommendations. And there really hasn't been a lot of work on this newer kind of trend of the higher intensity interval training type of work, and the potential risk in those short bouts of physical activity with the rise in blood pressure. So there's really not been a lot of evidence on it from an overall physiologic standpoint, as well as within hypertension. So next slide, please. Okay, so just kind of summarizing our types of exercise recommended, really the primary mode should be that continuous aerobic exercise to get the heart rate and the breathing up, and then including some dynamic resistance training. The evidence is a little weaker, but it's better for balance and maintaining muscle mass. Doing this in such a way to looking at lower weight and higher number of reps to have that lesser impact of the short increases in blood pressure that happen during resistance training. So next slide, please. Okay, and then just a few different resources available for physical activity information. Next slide, please. And then I wanted to quickly touch on obesity and hypertension. One of the common questions I get when I'm giving talks about diet and obesity outcomes, the common question I get is, which is more important, diet or exercise? And my answer is yes. Because they say, well, the diet people come in and say everything's about diet and you don't have to worry about exercise. And the exercise people come in and say it's all exercise and it doesn't really matter about diet. But I've always had the mantra that you can't outrun your mouth. You can eat, but you can't always exercise that away. Exercise doesn't cover all of our sins as far as diet goes. But the link of obesity to all of its other comorbid effects, blood pressure, glycated hemoglobin, cardiovascular disease, all of these different elements are very tightly linked together from both an etiologic perspective, but also a risk factors and contributors. So our octopus here really has when you're addressing one, you're really addressing many of the others. So I think taking this comprehensive approach to obesity management has these farther reaching impacts. When we're looking at an energy imbalance, if we're consuming too much, we need to then balance that energy equation from how much we take in and how much we expend. So when we're managing that, we're managing what we're consuming, and what we're consuming from the DASH diet has implications on our blood pressure as well. So by managing obesity, we're also managing all of the other comorbid conditions. So trying to disentangle them in a way becomes a challenge. And I think with that energy imbalance equation, the one thing I want to kind of end on is this idea of, is a calorie is a calorie? Because we say you need to reduce your caloric intake by 500 calories a day if you want to lose a pound a week. But we have to think about individuals in their energy balance based on a fulcrum. We've got a hinging point in the middle, and it's going to determine how much is enough. And if this fulcrum is moved out to one side, it may require more calories for an individual to lose weight because of the way their metabolism is balanced, versus for some individuals, a smaller amount of caloric restriction is going to require that change. So looking at these broader level pictures and this individualized approach to what people are consuming, how do we manage obesity, and how does that then link into hypertension? Obesity management in and of itself becomes a link to hypertension, but it utilizes all these different tentacles to have that impact. And from there, I will stop.
About the presentation. I have a couple of questions and comments, but let's see if Dr. Wright has anything you wanted to add or comment.
No.
Okay. Okay. So Chris, we do have a question from, let's see, from Sonia. Is there any truth to the metabolism types? Supposedly people with certain metabolism types should do certain types of exercise. For example, folks with type C, high cortisol metabolism, should not do exercise that increases heart rate, which theoretically increases cortisol level even more.
I am going to stay in my lane on this, and I won't be able to respond specifically to those metabolism types, and there might be some others in the room that can lead back to that. But I think it does hit in some of those important aspects around the personalized approach of recommendations to their needs, but also in creating an energy deficit. And I think sometimes we lose that within other elements, is that creating the energy deficit is what's going to be necessary. If others can speak to maybe some of these differences in metabolic types to the appropriate activity, but then trying to make sure that then gets translated into spending enough time that creates that deficit. Sorry, I know I can't answer that directly, but
Okay, I'm going to stay in my lane as well. But what we can do is do a little research here and talk with some of the folks and see if we can provide an answer to that question and then get back to the person who had the question. So we'll do that. One question I have is very basic, and that is I have not myself been in a visit with a dietitian or observed a visit with a dietitian, and I'm just assuming that an initial visit with a dietitian involves assessment and then dietary advice and maybe some health behavior change, motivational interviewing, but I'm speculating. So Chris, can you tell us what the typical format is for a consult with a dietitian when you send a patient to see them?
Yeah. And I think you do hit it right there on the head that the nutrition care process that we use is around all those very same types of things that you mentioned there, Jim. We do the assessment across anthropometrics, across biochemistry, clinical measures, background, as well as dietary intake. So we're really assessing across socio-behavioral, socio-demographic, dietary behavior patterns, medical history. So lots of different factors, which then does make that initial visit much more of an assessment to identify what is going on, what are the common issues. One of the things that I will say that I hear from dietitians is they get a referral from primary care, and when the patient is asked, so why are you in to see me today? Well, it's because the doctor said I needed to come see you, which makes it a little bit more difficult to kind of meet the goals of what you have or what you're really looking for. So I think that communication becomes a really important element to be able to link up, share what are your primary concerns that you'd like them to be able to address so that they can get honed in more specifically and then really meet those patients' needs. Assessment isn't easy and it isn't really quick. So a lot of that first visit really gets around identifying what their problems are, where are the opportunities for change and kind of starting that education. So then the follow-up really allows them to build on that more and to become more engaged in the kind of change process rather than the assessment process.
Okay, thank you for that explanation. That's helpful for me to understand that a little bit better. So physicians, a clinician should provide, if they can, more direction as to what they would like the dietitian to do with the patient and what the concern is, if there's a comorbidities that they are really concerned about, and that's why the referral is being made, that would be helpful to the dietitian. Okay, great. Let's, I think, move on to our case now. So Anissa Shomo is going to present, and she's from the Cincinnati Health Department Community Health Center. If you have questions or clarifying questions for Dr. Shomo, please type those into the chat box, or just you can even type in, I have a question, and Rick will recognize you so that you can go on the screen and ask your question. So I think we can ask Dr. Wright to comment. This is definitely, most of these questions are in his lane, so we'll let him weigh in on this.
Several issues. One is, first, in direct answer to your question on the use of chlorothalidone in patients who have CKD, I'll take you back to the ALLHAT trial, which had about 9,000 patients had 15,000 patients on chlorothalidone in that trial. About a third of whom had CKD, and renal function was followed in the trial. And in fact, there was no difference in change in renal function or deterioration in renal function in patients who were on chlorothalidone compared to lisinopril. It was a head-to-head comparison to lisinopril, chlorothalidone, amlodipine, and doxazosin. So the in the use of diuretics, you may see some decrease in GFR, but generally that is mostly because of the blood pressure lowering, in addition to some dehydration. But it's it does not present a problem, and in fact, those patients with CKD did just as well as those who were on the ACE inhibitor. In this patient is at her last visit was about 20 millimeters of mercury above her blood pressure target, even in those over age 75. The target is still less than 130 over 80. And so she's 20 millimeters mercury above her target, unlikely to be controlled with monotherapy. And so so you will have to add another agent. She does not have heart failure, does not have, by history that you present, a history of coronary disease. So therefore, the use of the beta blocker is, that would probably be third line and used for blood pressure control only in this patient, as opposed to the prevention of clinical events. With the CKD, in fact, it's going to be, in fact, diuretics are usually needed in order to control blood pressure in patients with CKD. So I would not avoid the thiazide. Her eGFR is 46. So chlorothalidone would be, or a higher dose of hydrochlorothiazide would in fact be a choice. Because it's CKD, she also would, a RAS inhibitor would be beneficial, and also because she is post-stroke, so that in those patients to prevent recurrent stroke, the thiazide type diuretic plus a RAS inhibitor, particularly the ARBs, would be potential targets. I think the key, though, is that one, because her blood pressure is elevated, her medications need to be intensified. The choice would be either a thiazide type diuretic, or in her with CKD and post-stroke, a RAS inhibitor plus a thiazide type diuretic. And to get her blood pressure down to less than 130.
Okay, terrific. Thank you, Dr. Wright. We do have a question from Dr. Joyce in Concord, Ohio. What does cause the blood pressure to jump suddenly? I have had one female patient, 74 years old, that went from 100 over 60 to 210 over 110. A second 42-year-old female went from 110 over 60 to 160 over 100. Both are medicated and controlled. I'm not sure why there was a sudden jump and how to work that up. Dr. Wright, would you like to comment on that?
Yeah, obviously the question becomes how the blood pressure is measured. Are we dealing with variability in blood pressure measurements? Are we dealing with variability in adherence? Typically, a blood pressure, don't forget, does go up and down, probably not to that extreme. But certainly, if she is on medication, then certainly changes in medication adherence changes in the ways in which the blood pressure are measured, and the accuracy of the measurements would be the most likely reasons for the variability.
Okay, great. All right. Dr. Shomo, do you have any other questions or remarks that you want to make?
Yeah. For me, I wondered if her blood pressure may have jumped because of, because I ordered physical therapy and maybe she was in more pain since she had been working with them. I wasn't really completely sure why, but I also wondered whether or not she was having any rebound from the metoprolol, which is why I thought maybe if she were going to be on that, she should have been on an extended release of it. But I also thought that, you know, probably going with the ACE or thiazide would be better, but I wanted to maximize the amlodipine first. The only issue, like in a lot of older people, is sometimes you can have swelling and constipation when you do that. So I usually monitor people for that. So I'll probably see her this week because it's been almost a month.
Yeah, yeah. Yeah, okay. That sounds reasonable. I think the major issue, does she have proteinuria?
I don't know that I've ever checked her for proteinuria.
Yeah, because that would be well. She already has the indication for the RAS inhibitor being post-stroke. So yeah, so she would that would be, rather than restarting the metoprolol, that may be the best bet, and then see what she does before adding the thiazide, or for that matter. Yeah.
Okay.
One thing too about high blood pressures, if it's outside your office, the major question, often patients will have elevated blood pressures with certainly in physical therapy. Again, the blood pressure measurement issues is one challenge. How accurately are those blood pressures being measured? So I assume I generally use the office readings as the readings that I follow, along with the home blood pressure readings. If you can get some readings at home, that may be another way of following her and getting a more accurate blood pressure measurements, because I think the home blood pressures would be the optimal.
Yeah, she was getting home physical therapy, and I think it was a nurse who took them. So she was getting home physical therapy, and she was also having nursing come visit her as well, just because. But I just didn't know, you know, because I know she told me like they wanted her to continue with physical therapy, and she told me that she did not want to continue with physical therapy because, you know, like a lot of my older patients, she's like, I'm 85. Like, what do you want me to do? Like run laps around the room, you know? So it's just trying to balance their quality of life, what that's acceptable for them, with, you know, me knowing that a year ago you were walking though, you know? So trying to know that she probably could get better versus that she doesn't really seem to be completely motivated to want to be, you know, moving around more. So
one point we'll make, when you talk about home blood pressure readings, having a visiting nurse take home blood pressures are not equivalent to the home blood pressure readings that are done by trained patients who are trained, or family members who are trained by you to, in fact, do them correctly.
yeah.
Okay, so there can be a lot of inaccuracy with home blood pressure measurements not taken by trained personnel, same as the blood pressure readings that you're getting in your office.
Yeah.
Check in with Chris Taylor. Chris, did you have any comments or questions for the presenter?
Not really. It seems like there are many other issues to be addressed. So stay
okay. That's fine. So, you know, this is an interesting case. The patient's 85 years old, and so the patient is it would be a different situation if the patient was much younger as far as mobility is concerned. But the patient, it seems at this point, is willing to accept a less mobility at this point in her life. And, you know, for me, I sort of have the natural reaction to say, could physical therapy help her improve her strength in her lower body so she could continue walking? But the motivation to do that, as you said, Dr. Shomo, doesn't quite seem to be there. And, you know, if you are interested in having a conversation with the patient about that, about what, what is really important to this patient at this point in their life. What do they really value, and what things do they want to be able to do? What things do they not want to be able to do? And then be able to tailor physical therapy or whatever else to their needs. And you may have already done this, or it may be sort of implicit in what the patient's attitude and actions are. But I wonder, what's important to this patient right now at age 85?
Yeah, I think the most important thing for her is to not be in as much pain. So I have been prescribing her. I didn't have her on oxycodone for a while. When she first came to see me out of the nursing home, she was on oxycodone, but I was just kind of like, well, I don't really want you to be on that long term because there can be issues with that and that sort of thing. So I had been trying to manage her on gabapentin, and then that's when she kind of started gaining weight and that sort of thing and not as mobile. So then I was trying to put her back on the oxycodone to see if that would help with her mobility. And I also refer her pain management to see, what else we could do. And then I started her on some Balta. So she's been coming to see me more about her pain. And that's what's important to her, is having less pain. So that's what we've been working on. But in the meantime, I'm just like, I really want you to try to work on getting stronger. Like, I want you to be on pain medicine so that you can have some mobility, because it's important. I mean, I know as a geriatrician, like, to preventing falls and that sort of thing, to be able to have some mobility that will decrease the disability. And if she had been bedbound forever, that's one thing. But I'm like, when I met you, you were walking, when I met you 18 months ago, you were walking without a problem, But I think for her, she feels like maybe she'll walk more if her pain was better controlled. So that's what we've been trying to work on.
Mm-hmm. So the pain is really dominating kind of her focus right now, which is understandable. And if the pain could be controlled, there may be other things that she wants to be able to do in her life that right now she's just, really focused on the pain management. So it's interesting that this patient is both coming to see you, and so she's ambulatory enough to be able to do that, but she's getting home health care as well. So how is it that she's coming in to see you? Is she in a wheelchair, or what's her mobility?
She's in a wheelchair when she comes to see me. So she was coming to see me because she wanted a motorized wheelchair.
I checked with a home care agency, and as far as being able to get referral for home care for a patient like this, osteoarthritis in a lower extremity is qualifies, but you must specify the joint. Rheumatoid arthritis specifies, but you have to indicate if they're seropositive or seronegative. And muscle atrophy does as well. Muscle weakness or generalized weakness does not qualify for home care. So just some information about making those referrals to home care. Okay. Does anyone have any other questions, final questions or final comments? Dr. Shomo, do you have anything else that you wanted to ask Dr. Wright or the other content experts?
No, that was it.
Okay. All right. Thank you. We'll turn it over to Shannon.
Thank you.
Thanks everyone for joining today. Special thanks to Chris Taylor again for switching up this week. He was supposed to have 2 more weeks to work on that presentation, but you did great. Thank you so much. We have previous ECHO clinics on our website. Please register to view them. You have received a survey to complete for the post-clinic evaluation, and you have until 5 o'clock tomorrow to complete that. And next week, we have Dr. Rao with special populations, children and adolescents. So we'll see you next week, same time, same place. Thank you.
Thanks,
Have
everyone.
a good day.